Well, hello, everyone, and welcome to today's inaugural meeting of the Davos Alzheimer's Collaborative Learning Laboratory, dealing with the changing role of health systems in an aging society. My name is George Vredenberg. I'm the co-chair of the Davos Alzheimer's Collaborative. This is a global effort convened by the Global CEO Initiative on Alzheimer's Disease and the World Economic Forum. Its role is to eradicate Alzheimer's disease, something that now looks to be so far in the future is to be a major challenge. But if we don't do it and start now, we'll never get there. So advised by hundreds of global experts, DAC, as it's affectionately known, is partnering to advance this goal with so many of you on this phone today. I'd like to thank everyone on behalf of the Davos Alzheimer's Collaborative for joining us today. We have representatives from almost 10 governments around the world, and all continents are represented in today's call. As we all know, Alzheimer's is a global pandemic that is devastating families, challenging health systems, and impacting the global economy. Today, we're at the cusp of a new era in the treatment of Alzheimer's disease with new therapeutics coming through the pipeline. Can we put up the slide? Thank you. This is a slide that the Japanese government has used to highlight the changes which have occurred as a result of aging societies. The 19th and 20th centuries have been driven by communicable diseases. The 21st century is being driven by non-communicable diseases and the chronic diseases of aging. And in the 21st century, in the face of the megatrend of aging populations, healthcare systems are challenged now to detect and prevent disease of later life rather than treating disease in its later symptomatic stages. This is particularly true with respect to Alzheimer's. Our challenges: we have not adapted to low-cost, easy-to-use technologies to detect and diagnose disease in Alzheimer's in the 20 years when disease conditions develop and before symptoms occur. Therapeutic agents and risk reduction strategies needed to slow or prevent disease are just emerging, but certainly not yet at a global scale. And we do not have the protocols for physicians to integrate therapeutic or non-therapeutic interventions into clinical practice or to include clinical research opportunities into standard clinical care. Today, we're gathered to learn from each other on how best to change this trajectory. This meeting marks the first meeting of the Davos Alzheimer's Collaborative Learning Laboratory, a mechanism by which stakeholders from high, medium, and low resource settings and across all sectors, national public health organizations, policy, research, and industry, can come together to share learnings about shared operational challenges in preventing and ultimately eradicating Alzheimer's. Tackling Alzheimer's disease cannot be done by a single country or sector, but must be addressed by linking and scaling disparate efforts across the globe. I'm confident together through this collaborative learning laboratory, we can take on that challenge. I would now like to turn the conversation over to David Bloom, the Clarence James Gamble Professor of Economics and Demography at the Global Health Population Center at the Harvard T.H. Chan School of Public Health. David is currently working with us at the Davos Alzheimer's Collaborative, the CEOi, and the World Economic Forum on research looking at the impact of Alzheimer's disease and related dementias to health systems and every society more broadly. David, all yours.
Thank you, George, and good day, everyone. By way of a bit of background here, I've spent a good deal of time during the past bunch of months working pretty intensively with a crack team of researchers whose disciplinary specialties range from geriatrics and psychiatry to biology and public health to data science and economics. Our focus has been on the what, the so what, and the now what of Alzheimer's disease and related dementias, which I'll refer to in my remarks as ADRDs. I'd also note that a core focus of my research team has been on looking at these issues through the lens of economics, also from a global perspective and with a strong focus on investment in unmet R&D needs. When I say the what, I'm referring to basic facts and forecasts concerning the prevalence of ADRDs and also their geographic distribution. The so what refers to the myriad individual, familial, and societal issues indicated by the facts and forecasts, and also the corresponding expectation of relentless impairment of people's cognition, judgment, and ultimately their prospects for survival. And then we have the now what, which refers to the pros and cons of selected options we currently have for addressing ADRDs and the challenges they pose. Our research efforts have encompassed everything from the review of published and gray literature to conceptual thinking and model building to statistical analysis. We hope to report or to launch our report later this summer. So I thought what I would use my 5 minutes today is to offer a high-level sketch of our key findings, conclusions, and recommendations. So I'll divide them up into points. Point one, ADRDs already impose health, economic, and social burdens that are large by any reasonable yardstick. Point two, ADRDs will predictably and increasingly impose in the remainder of this half century health, social, and economic burdens that are on track to be absolutely staggering. Point three, whereas the current burdens are concentrated in the wealthy industrial countries of the world, the future burdens will be much more evenly dispersed throughout the world. And that's mainly a reflection of coming shifts in the global distribution of aged populations. Point four, these findings our findings point toward the urgency of acting big and acting now, especially, I would say, in the domain of R&D spending on prevention, early detection, and disease-modifying therapies. Along those lines, a high-impact path forward involves transformational increases in cross-national and cross-sectoral data sharing and research cooperation and coordination. The optimal path here also involves public policymakers throughout the world taking the lead on enabling or conducting necessary basic research and using that to subsequently unleash the power of the private sector to apply and develop it. Just to put it another way, what we need to do is to build an R&D ecosystem for ADRDs that has a carefully defined public-private division of responsibility and that front-loads support from a coalition of governments throughout the world. In this vein, our research makes clear and documents the enormously high cost of inaction. In other words, the high cost of falling prey to what is now an all too familiar but grossly suboptimal cycle of neglect and panic. In other words, the pattern of neglecting health challenges until they're in our midst and then scrambling desperately to catch up and address them. Our research also provides rigorous evidence in support of a transformational boost in the resources we invest in R&D for preventive, diagnostic, and therapeutic interventions for ADRDs. Now, for purposes of this meeting, I'm going to spare you the details of our data, models, methods, and statistics. But I will reiterate, and thereby stress, that we adopt predominantly an economic approach to ADRDs, which includes efforts to monetize their burdens. And to my mind, monetization has three great virtues. First, monetary estimates are useful because they draw the attention and speak the language of policymakers who are accountable for economic growth and poverty reduction. So I'm thinking here of folks with the power of the purse, who often happen to be the same folks as those whose cooperation and proactive leadership will be absolutely essential to tackling the multiplicity and the large-scale nature of the challenges posed by ADRDs. A second virtue of adopting an economic approach is that it allows us to make decisively the point that the full societal burden of ADRDs is substantially larger, many times larger than the health impacts and healthcare costs borne by those experiencing ADRDs. Now, that would have been a rather controversial point some years ago, but as we all know, the experience of COVID-19 has taken it out of academic circles and made it absolutely self-evident to policymakers and people throughout the world, the negative effects of health issues on everything from productivity and income to peace of mind and social and economic inequities. And the final virtue of adopting a broad economic perspective to studying ADRDs is that it protects us against the pitfalls of underinvestment in innovation and underspending on the provision of different interventions. The protection comes from the fact that proper valuation of the health, economic, and social burdens of ADRDs is necessary if we're going to do proper valuation of preventive, diagnostic, and treatment interventions for ADRDs. ADRDs are akin to an albatross around the neck of humanity, an albatross that's growing heavier by the decade and mercilessly diminishing population health and well-being. Yes, we do have some defenses. For example, we have some decent care models that are worthy of expansion and that face the challenge of underinvestment in their own right. And we also know that vascular dementia can be at least partially prevented with antihypertensives. But with respect to interventions for the prevention, the early detection, and the treatment of Alzheimer's disease, the world is currently close to defenseless and extremely vulnerable. That's a very bad position for us to be in, which is why I applaud the efforts of the Davos Alzheimer's Collaborative to formulate a forward-looking and appropriately ambitious ADRD defense plan, and also to help make sure we have the capacity and the support to implement it. Thank you, George. I'll stop there.
You are mute.
George, you're on mute.
You are mute.
Oh, and it was so brilliant too. Thank you, David, for those critical insights, and look forward to your full report this summer. Driving action against Alzheimer's across governments and other sectors is our fundamental goal. With that in mind, I'm pleased to introduce our keynote speaker, a member of the European Parliament and former Minister of Health, Social Services and Equality in Spain, Dolores Montserrat, to speak with us about the catalytic role of global mechanisms to address challenges raised and faced by healthcare systems. Dolores, thank you for joining us today.
Thank you very much, George, to be here again with you. Thank you very much for the opportunity to give this keynote addressing the catalytic role of global mechanisms like the Davos Alzheimer Collaborative Learning Laboratory to tackle global public health issues, including Alzheimer's disease. Europe leads the world in life expectancy with 78 years for men and almost 44 for women. The percentage of people aged 60 years and older will keep growing, thanks to our welfare state and our universal free public healthcare systems in Europe. These remarkable achievements pose challenge and offer opportunities. Together with the green and digital transition, demographic change is the third transformation shaping the future of Europe. Today, 10 million people aged over 60 across Europe suffer from Alzheimer's disease and other forms of dementia. And this number will grow to more than 40 million by 2040. Alzheimer's is not only a health disease, but also a social, employment, and economic threat, which to be effectively faced needs more European Union centralized and coordinate actions. The European Union can and should take leadership in flattening the Alzheimer's disease curve and facing the global challenge of unmet clinical need and social impact of this neurodegenerative disease. The Davos Alzheimer Collaborative is a promising global incubator of Alzheimer's research and innovation that it's bringing together the entire global ecosystem of players, governments, health systems, private sector, and researchers to drive progress. Brain research funding in Europe has increased and amounts to 3.2 billion euros under program Horizon 2014 to 2020, the previous European Union research program. Regarding the new Horizon Europe program for 2021 to 2027, which we in the European Parliament just approved in last May, brain research will remain a priority as well as an international cooperation with third countries and other international partners. Horizon Europe goals reflect the new commitment that we at the European Union have pledged to health, fostering what we believe will be the European decade of health. Moreover, the European Commission presented in May the new European Union global approach to research and innovation in order to respond to today's very different global context and to adapt the Union's international cooperation to its current political priorities. In particular, it raised the need for Europe to enhance its partnerships in a multilateral manner to address today's urgent global challenge, such as climate change and health crises, and to the ecological and digital transitions. We have to further support the mentioned research and development within a multilateral public-private global framework by fostering a risk-taking approach, encouraging co-development of research, and facilitating a strategic and operative ecosystems of cooperation. The European Union strategy for COVID-19 vaccines is a successful example of this kind of framework. The lessons learned from the COVID-19 pandemic clearly show that one country alone or only the public institutions could not overcome a health threat which knows no borders. The European Commission and the Parliament together, we are building a new, stronger and more prepared union of health with more competence and more centrally coordinated actions. The union of health that we are building will have a mental health pillar, and we need to establish it according to a global perspective through global alliance and coordinate policies to prevent possible silent epidemic. With life expectancy growing, the number of people potentially in need of long-term care is also increasing. Ensuring access, affordability, and quality, as well as adequate healthcare professionals and trained family carers, will be a common health and social challenge. Healthcare systems preparedness is key. Planning ahead and making healthcare systems fit for the future requires awareness raising about the disease, particularly the first warnings of early dementia. Second, training primary care physicians to identify early symptoms of Alzheimer's disease and support systematic screening of at-risk population. Third, ensure access to Alzheimer's detection and timely diagnosis, as well as potential treatments when they become available. And social analysis of Alzheimer's incidence clearly show that socio-economically vulnerable groups of population are much more affected by this disease. So this evidence underlines risk of discrimination and social disparities in health access, calling for integrated solutions in the social and health dimensions to establish social policies for supporting families and carers in family environments and promote healthy aging and cognitive training that effectively reduce the prevalence of this disease, to tackle our dependence with less dependence. So we urgently need to strengthen North-South, South-South, and triangular cooperation to implement a global dementia health and socioeconomic research agenda, as well as a new clinical trial system and big data, digital interoperable systems that will increase the effective progress globally towards better prevention, diagnosis, treatment, and care for people with dementia. So the DAC Learning Laboratory represents a mechanism perfectly matching the ambitious goals we set, sharing learnings from Alzheimer's research initiatives aimed at common operational challenge in healthcare system preparedness, and therefore calling policymakers for action. I'm proud to say that Spain and Barcelona, my city in particular, with the Medical Foundation Alzheimer's Center Barcelona, has been a world leader in Alzheimer's research in the last 15 years, and an example of excellence in research collaboration with the United States in the framework of the AMBER study, an international multi-center clinical trial in which patients with mild and moderate Alzheimer's disease from 41 Spanish and American hospitals have participated. So initiatives like the WHO Global Action Plan on the Public Health Response to Dementia 2017 to 2025, the Global Dementia Observatory just launched by the WHO, the new European Union of Health, and the Davos Alzheimer Collaborative are showing the right path to follow. fostering a global collaboration with no borders, sharing resource, scientific knowledge, and real-world data, while promoting public-private partnerships to avoid research duplication and optimize the effective use of resource, represents the only way we can face this challenge and prevent a future dementia pandemic. So for me, it's very important, this initiative, George, that you are leading with Davos, because this is a call to action for all the national governments and public institutions to join the DAC initiative and promote the exchange of the learning laboratory to prepare the national health systems to prevent and get prepared to face the Alzheimer's disease impact in our societies. After the COVID pandemic, we have another silence pandemics. I'm thinking in mental health, in the resistance of antimicrobials too. But the third one is the neurodegenerative disease like Alzheimer's. So let's do it together. So thank you very much, George, and all of you.
Dolores, thank you so very much for articulating precisely the need for this learning laboratory and the need for cooperative learning around the world. Health systems tend to be national or subnational, but they cannot operate without a strong policy environment and a research support pathway. So thank you for articulating the need for this learning lab so articulately. It's now my pleasure to turn today's discussion over to Phyllis Farrell. She is the global head of external engagement for Alzheimer's and neurodegeneration at Eli Lilly and Company. She is also the director of the Healthcare System Preparedness Initiative within the Davos Alzheimer's Collaborative. Phyllis, to you.
Thank you, George. And I'd really like to build on Ms. Montserrat's comments around the importance of healthcare system preparedness. And so she really laid an excellent foundation here. You know, I think it's important that we first step back and realize that there have been so many scientific advances. We've really moved the knowledge of Alzheimer's disease forward in the scientific community, but these new innovations and this knowledge is largely locked away in academic settings and publications. And while they're peer-reviewed, they're not moving into clinical practice. And as a result, a very large proportion of the healthcare systems around the world and the patients and families that are in them, they're interacting within an operating system that's several decades behind where the current research and documented evidence-based practices are now. So this poses several challenges for us. Of course, one of the most immediate and measurable and visible is that clinical trials are unnecessarily under-recruited and delayed because patients are not diagnosed early enough or referred, and in a way that they can actually consider participation in Alzheimer's trials of these disease-modifying therapies, which are going to be so critical to tackling these public health challenges. So we see that very visibly, of course. But the other thing, and Ms. Montserrat mentioned this, not only does our current system rob patients and their families of the choice to participate in a clinical trial, but this is a progressive neurodegenerative disease, and the challenges are predictable, but families often face these challenges as a crisis when the diagnosis happens late. And the caregivers that have the least ability to weather the expenses and the lost wages that are faced by an emergency diagnosis, they're the most vulnerable of our population. They're often not referred to local agencies or support systems, and we have resources that are going unused while the burden is unnecessarily crushing the family. And even when patients are referred, those support systems are likely to be under-resourced or ill-equipped to handle our aging population and the volume that's coming in a high-quality manner. Once again, Alzheimer's disease is a progressive neurodegenerative disorder. Once these synapses face neuronal death and cognition is lost, those memories are gone forever. Our COVID pandemic has highlighted that our system gaps in caring for people as they age are significant, but it's also shown us that what we can accomplish is great if we work together, and it would be a tragedy to lose sight of these learnings. So our healthcare system preparedness work group basically wanted to create an environment where we could learn together and tackle this problem globally. And so transforming any healthcare system to enable the early detection and diagnosis of a disease is a massive operational challenge, but it is an operational challenge. And like engineering issues, these problems can be solved with resources and commitment. If we determine actionable steps now and we identify the root causes today, we can test solutions that have clear and measurable operational outcomes, and we will make progress for the systems of tomorrow. We shouldn't be waiting when patients can benefit today. So the Healthcare System Readiness Work Group was assembled with key members across sectors and disciplines to ensure that all perspectives were included. It included representatives from industry, academia, practitioners, public health organizations, nonprofits, NGOs, and experts in research, diagnostics, therapeutics, health policy, and home care, and even measurement, because it matters what we measure. You'll hear from some of those experts in a little bit today. The first thing we did was actually put together the definition of the problem that we are trying to tackle, and that's defining healthcare system preparedness. And we use the patient pathway because everything we're doing starts with the patient and starts with the science. And this isn't what you see in front of you, which you can also find on the Davos Alzheimer's Collaborative website. This is the patient pathway of healthcare system preparedness. And each of these individual nodes will allow us to tackle a discrete and measurable part of the challenge. Our primary goal is to help build an ecosystem that can speed innovation with a direct focus on awareness and activation in this first section, timely and accurate diagnosis, and broad access to pharmacological and non-pharmacological treatments and services. So this solution targets the three aspects of the patient pathway: the awareness and activation of brain health for all key stakeholders. In the middle, the healthcare system for the timely detection of cognitive symptoms and accurate diagnosis of Alzheimer's pathology. And then third, the post-diagnostic therapeutic and non-therapeutic person-centered care and support. These modules are the building blocks of a prepared healthcare system. Back to you, George.
Getting off mute, you'd think after a year and a half of this, one would remember to go off mute. Thank you so very much, Phyllis. You're so right that this is an operational challenge, but one that we can dissect into measurable, specific, actionable steps, and then address them each collaboratively and in a learning framework that respects all the players needed to develop that operational solution. I would now like to introduce Tyrone Dua, a medical officer for the Program for Neurological Diseases and Neuroscience in the Management of Mental Health and Brain Disorders at the World Health Organization's Department of Mental Health and Substance Abuse. She'll be moderating this next discussion on the need for coordinated action to address healthcare system challenges. WHO has taken a global lead on challenging Alzheimer's disease with its Global Action Plan mentioned earlier, approved in 2017, and the subsequent Global Dementia Observatory. As a partner, a technical advisor to the Davos Alzheimer's Collaborative, I am looking forward to the work that WHO and the DAC initiative can accomplish together to tackle this disease. Tarun, the floor is yours.
Thank you, George, and thanks for inviting me. So as George mentioned about the Global Action Plan on Public Health Response to Dementia, its implementation and the achievement of the ambitious targets that the plan has come up with requires partnerships and collaboration. And we are very excited to see the work that is happening through the Davos Alzheimer's Collaborative. And this topic that we are discussing today, health system preparedness, is very close to our heart. So I'm going to move to my esteemed panelists. I see Martin and I see Nancy, and I'm looking for the other two. Maybe they are not on my screen. Soren, are you there? And Jennifer? If you can switch on your video, please.
Here.
Hi, Jerome, I'm here. Jennifer speaking. Too early for me. Excuse me. I won't switch on my video today.
Okay, Jennifer, but good to hear your voice. Doesn't sound it's too early for you, but very nice. And Soren, may I ask you to switch on the video if you don't mind?
I'm here, but not video ready. So.
Okay, no worries. Okay, that doesn't matter. Okay, but great. We have the panelists, so let me introduce them one by one. Martin Knapp, whom you can see. Martin, if you, he's the from London School of Economics, has been working in the field of dementia and many other conditions for many years, and running and coordinating the STRIDE initiative. So, and then we have Jennifer, who is from African Academy of Sciences, Nancy from Hong Kong University of Science and Technology, and Soren from University of South California. I know we are in very different time zones, so let me start with Martin, who's kind of in a nice afternoon time zone here, Martin, to get the discussion kick-started. So tell us, we've been looking at the health system preparedness, and the one issue that comes up is the economic challenges in dealing with dementia. So what do you see are the challenges, and how can we overcome them? Over to you, Martin.
So thank you, Tarun, and thank you everybody else for inviting me today. So, I mean, David Bloom gave us a very clear description of the currently very high and in future much higher costs associated with dementia. I'm going to use the term dementia, and also how those costs, those economic impacts, are not distributed evenly across the world or across the population. So I'm going to say something in a moment about the STRIDE project, which we are working on in 7 countries across the world. But first of all, I've just got a slide. I'm not sure whether Alyssa can show my slide. Yes, thank you very much, or Krishna, thank you. So I just wanted, is just to remind me what I'm going to say, so I don't wander too far off track. I just think there are 4 areas perhaps where we can think about making the economic case: prevention, disease modification, care and support, and then support of families and other caregivers. So let me say a few words about those. So on the prevention side, and again, I think, from comments that were made by previous speakers, we've had good introduction to actually each of these areas. On the prevention side, there are things that we can do. The trouble is that they're going to take a very long time to show their impact in terms of numbers of people living with dementia, the severity of their dementia, the period over which they are experiencing their symptoms and damage to their quality of life. But there are things we can do, and we've been doing some work recently looking at the economic case for midlife actions. What can we do to reduce hypertension? What can we do to help people to manage their diabetes, or maybe prevent diabetes? What can we do in relation to hearing loss or smoking cessation? And for those 4 areas, there's a really strong economic case for doing something, even if you only focus on the impact on Alzheimer's and other dementias. But of course, the policymakers, the funders, will have to wait 3 or 4 decades before they will see that economic return, if you like. We've then got interventions like the FINGER study, led by Mia Kivipelto, and now being trialed across many countries, which is working at a much later stage. People are showing the early signs of cognitive decline and dementia. And that again is very effective, and it looks like it's cost effective too. So there are things we can do, but generally speaking, they're slow to show an impact. On disease modification, we're in the middle of a very exciting period now. Lots of companies, lots of researchers around the world trying to make these breakthroughs. The challenge for us today in the discussion is not so much, well, it is about the breakthroughs, but if a breakthrough is then achieved, how can we make the treatments affordable, particularly affordable in low resource settings? And that is a huge challenge, because companies that develop these new approaches they are spending millions, billions of dollars in research, and they need to be able to get a return on their investment. So it's a bit of a challenge there, a bit of a balancing act. The third area is better care and support, and we have now some evidence. It's still relatively modest in the volume of it, but we have got evidence, mainly from high-income countries in the world, of things we can do, whether it's in terms of cognitive stimulation or better support for carers, which I'll come back to in a moment, and so on. But what we've got to do is to make sure we can improve the care, the health and the quality of life of people living with dementia who are living in the community, help them to stay living in their own homes for longer. I think we have got evidence of what we can do to some extent to improve their lives. The problem is, I think, rolling it out, making the commitment to invest in those things across our countries and across the world. And that takes me to family caregivers. And David talked about the costs associated with Alzheimer's disease and related conditions. And in the countries I know, the biggest cost is carried by families, carried by the unpaid hidden sector of family and other supporters. And we have to do something. We really, really have to do something to support those people, because they are so crucial to our systems of care and support today. And that means supporting them to improve their own quality of life, to allow them to be compensated for the income losses they may experience, to help them to avoid poor health outcomes. So what do we know? I'm not going to go through, obviously, a huge range of things, but just to mention a couple of things quickly. So the STRIDE project, which has been mentioned already, is the STR words are strengthening responses to dementia in developing countries, in lower middle income countries. And we're working in 7 countries around the world, and I'm delighted that Ishtar Govia is on the meeting today and is representing one of the countries, leads one of the work streams. So what we're trying to do is working with governments, with third sector bodies, with researchers to build capacity to develop evidence to improve the lives of people with dementia, improve the lives of carers. We've got this evidence synthesis. We've just finished a mapping of evidence on randomized trials, 340 randomized trials. And for the first time, I think in this area, we've searched in 15 languages, made a real effort, which most people don't do, to look at evidence in non-English languages. And we find a lot in non-English languages. So we're synthesizing that evidence now, and we'll put that out into the public domain as soon as we can. And my final comment is learning. We need to learn from each other, and we have to remember, those of us that live in the north of this planet, that it's not learning from the north to the south. It's learning across our countries and in all directions. And if we do that, I think we're in a better position. So thank you very much, Tarun.
Thanks, Martin. And I think it's clearly the key message, as you said, is the key is learning across countries. And we will hear some of these examples in the next session. Alyssa, thanks, Alyssa, for posting in the chat. So please, if you have any questions, please post them in the chat function and we'll try to get to them. And I'm now going to ask Jennifer, with her experience and work in African continent and working with the conditions such as HIV. So when we look at health systems preparedness, what are the key lessons we can draw from HIV field that can be applied to dementia, including Alzheimer's disease? Jennifer.
Yeah, thank you very much, Tarun, for inviting me and to speak at this moment. So again, I will just take a couple minutes here to just reflect on the lessons from HIV and how we could potentially apply this to prevent an Alzheimer's epidemic. But I also have to acknowledge that these two diseases are very different, but in many ways they do share some similarities that we could learn from. And before we even get into the details of the healthcare systems themselves, the first thing that I really wanted to mention and talk about is the stigma associated with both of these diseases. So as you know, in Africa, when HIV was a problem and mostly it was seen as a sexually transmitted disease. And so any patient that were positive brought shame to the patient and to their families. And it was always assumed that one has gotten it due to promiscuous behavior, and therefore was shunned by community. And we also do acknowledge that before antiretroviral drugs were rolled out, many people suffered with AIDS, which was, very characteristic, and people could easily point out who is potentially infected with HIV and therefore suffering from AIDS. And before long, any form of weight loss was associated with being HIV positive. And this was very difficult for sick patients to go out for testing or to seek any form of help. And so in the context of HIV, African governments were involved in massive campaigns, really to educate their populations and to demystify the HIV and its mode of transmission and everything else. So there were lots of campaigns across schools, local televisions, roadside billboards. Literally, the message was everywhere. And this really helped in educating the population and letting the population take ownership of the problem and become part of the solution. Similarly, individuals with dementia and those also with Alzheimer's can easily be identified within our communities. There are many myths that surround these conditions, but the most common is also the belief that it could potentially be due to witchcraft. And many families would prefer to hide one of their own than expose themselves by going out to seek medical help. And in most cases, any medical help that they would seek would potentially be from traditional healers instead of going to typical hospitals. And therefore, I think that an intensive campaign that involves government and private sector to educate communities on Alzheimer's will help hugely in creating safe spaces for both the patients and their caregivers. So that's my point number one. The second point is with regard to healthcare needs and treatment. So to date, the healthcare systems in Africa continue to be weak, and they are highly vulnerable. I think we all acknowledge that. But that said, we must acknowledge the fact that there was tremendous progress that was made in strengthening these healthcare systems simply to serve HIV patients. A lot of investments went into this, and those systems continue to exist now and continue to serve beyond HIV patients alone. Early in the epidemic, we also know that treatment was not available. It was not accessible for people in low and middle income countries, and also particularly in Africa. And eventually, when it became available, it was too expensive for most people to access it. And in the context of HIV, what did governments do together with the global partners? Testing centers were developed and equipped to provide free testing. Healthcare workers were empowered to handle HIV patients and their extended needs. HIV comprehensive care centers were built to provide all services under one roof. So testing, treatment, follow-up, and psychosocial support. And importantly, I think the US President's Emergency Plan for AIDS Relief, commonly referred to as PEPFAR, which was implemented in 2003, tremendously increased the access to treatment and has since then saved millions of lives and significantly averted new HIV infections. And finally, use of mobile technology to track and follow up patients, to send reminders for drug adherence, has provided quite a good platform for the follow-up of HIV, people living with HIV and AIDS who are on treatment. And so similarly, healthcare facilities are ill-equipped to serve Alzheimer's patients at the moment on the African continent. However, these existing structures and some of the lessons learned, as I've mentioned above, could probably be strengthened to fill the gaps. And finally, the third point I wanted to mention is on research. And most people have talked about clinical research around Alzheimer's. In the context of HIV, it was a new virus, so we needed to learn a lot. And so a lot of research was going on around the world, but particularly in Africa, because the epidemic was focused really on the African continent. And so it was easy to get to access the patient participants for this research. These investments, of course, produced a lot of data, new knowledge, but also they led to improvement of infrastructure for research and development that continues to serve other disease areas today. in relation to Alzheimer's, not much research is happening on Alzheimer's on the African continent. And therefore, we do need to look at a way in which we can promote research in this area so that adequate, local, and relevant research is done on the ground to better inform a targeted response to the needs of the African population that is going through both either Alzheimer's or other dementia-related illnesses. And I'll stop there for now and will be available for questions. Thank you.
Thanks, Jennifer. So, I mean, if I can summarize, what we heard is as we are thinking about health system preparedness, patient awareness or public awareness is extremely important. So this has to be part of any strategies. Two, that there are systems built up through HIV that can be piggybacked or synergies explored for service delivery for non-communicable diseases such as dementia, Alzheimer's disease, and similarly to use the research infrastructure that exists for other conditions. And I think just to add that one, we know that when we are thinking about because of limited capacity in low and middle income countries, any research that we think about should be embedded in as part of the clinical facilities, not to take away the manpower from what is already happening. So I think thanks, Jennifer, for sharing these key lessons, very important. We're going to move on to Soren and think from the perspective of United States, moving from Africa to US. If we look at US and the Alzheimer's infrastructure and the landscape, where do you think things are currently, and what do you see as some of the key challenges to early detection of Alzheimer's disease? Soren, the floor is yours.
Yeah, thank you. And the challenges with treating Alzheimer's disease specifically requires an accurate diagnosis of the underlying pathology. So we need to know whether this is the 50% of cases that are actually due to Alzheimer's disease or the other half that is not. And that requires a biomarker-based diagnosis of the Alzheimer's pathology. At the moment, this is predominantly done with PET scans, and not even in high-income countries will we have the capacity to conduct PET scans in the vast number of people that actually need that biomarker diagnosis. And it's neither feasible nor economically attractive to build the capacity to diagnose the large number of prevalent cases. If you look at the world right now, we have very many people, we have this large backlog of cases that have never been formally diagnosed because there was no disease-modifying treatment. If you want to get to those people, you need to diagnose a large number of folks at the moment, and you cannot build an infrastructure that is sufficient to diagnose that number of prevalent cases and maintain it for the future, meaning that you need to have a scalable technology that can be used not just in high-income countries, but also in lower and middle-income countries to make the treatment available and targeted to the right people. So if PET scan is not the option, where do we go? There are established technologies based on cerebral spinal fluid to diagnose Alzheimer's disease, but there are, of course, strong, what I would call antibodies in many countries to getting that procedure. And that's a very sort of cultural and social system related restraint that many people do not like to get a spinal tap because of fear of complications and side effects. So while that technology is readily available and scalable, many patients are actually reluctant to accept it. So if that's the case, where do we go? There is the now increasing opportunity to use blood-based biomarkers, at least as a triage tool, to support the the diagnostic process. In other words, even with currently available biomarker tests, a blood-based biomarker test can give you a reasonable suspicion that a patient has the Alzheimer's pathology, and a cognitive test can give you a reasonable suspicion that there's early stage cognitive decline. And the combination of those two findings will give you a way to triage patients that are most likely to benefit from a disease-modifying treatment that targets the amyloid pathology. And in many countries, at least in high-income settings, that allows you a triage process to sort of specifically send patients into the further diagnostic funnel that might benefit from a disease-modifying treatment. So with that technology, we are in a position to send patients to scarce resources that are likely to benefit, and therefore handle the triage process without building up an enormous testing and diagnostic infrastructure. The advantage of blood-based biomarkers is also that they're readily scalable in lower and middle income countries, because blood draws are possible in many settings. And once we get down the cost of these assays, we can actually diagnose precisely Alzheimer's treatment even in low and middle income countries, and then target patients for further treatment, just like that Jennifer explained we did in HIV treatment.
Thank you very much, Soren. And I think the importance of scalable technology, but also something that is scalable by the primary healthcare providers and doesn't require the specialists, because that's also a bottleneck we have in low and middle income countries. And I think that's the kind of the way to go if we have to get treatments and therapies made available to all people with dementia. So can you guys hear me? It seems my computer has frozen.
No, we can hear you.
Okay. I don't know, my screen, it got frozen, so I can't see your, and so I don't know. Okay. On to Nancy, and Nancy, yes.
Yes, I'm here.
Apologies, I can't seem to hear anything.
Yes, I'm here.
Something is wrong with my system.
So Nancy, why don't you go ahead, and when Tarun gets back online, we can let her know that you've already started.
It's okay. So I want to take this opportunity to share with you some of my thoughts on how we can turn data that we collect into useful information and enhance data sharing and collaboration. So Elise already shared the screen with you. So as Soren just mentioned, it is really difficult to build the capacity to diagnose AD patients in some countries because of the inadequate infrastructure. So I listed on the left-hand side, those systems and approaches that Soren already very nicely summarized, including brain imaging, biomarkers in CSF, and also genomic information. Again, as Soren just summarized very nicely, there are new technologies emerging, and these include, for example, imaging the blood vessel in the eyes, and also digital phenotyping using mobile or wearable devices. And recently, the blood tests, using multiplex format, can also allow accurate AD diagnosis and staging. So it is widely accepted that we can, detect changes in the brains by just examining the blood profiles. So the data can be quickly analyzed and can be cataloged for a longitudinal assessment of possible cognitive decline. So I think the new technologies can come in very handy, and they can be scalable in middle income, low income countries. So how do we turn this data into useful information? I believe it is important to develop standard methods of defined criteria that can be applied to analyzing the data from a large number of participants across multi-centers. It is very important to implement these tests in multi-centers with standard operating procedures, so-called SOPs, in order to evaluate the performance in diagnosing AD. So again, another point is that we must standardize the methods for data analysis in order to be able to interpret the data. So one additional point is that cloud computing allows the real-time processing of large volumes of data, which can facilitate risk detection or early screening of the disease on a population scale. So Elisa, if you can move to the next slide. Next slide. Okay, thank you. So how can we combine the different records and what is being collected into an easily accessible database that will facilitate better sharing of information and also enhance collaboration? One important point is that we have to organize the data from multiple platforms in a logical manner and well-designed hierarchy. So we should take note of good examples from cohort studies such as the Framingham study, ACNI, and also the UK Biobank. These examples, these studies, they work on really well-defined cohorts. That is, the phenotypes of individuals are being assessed by a standard set of technologies using SOPs. And they have a very well-documented system for cohort studies and also a well-designed system for data storage and also sharing. So this system should be able to allow the analysis of data from multiple centers and also generalization of data from different sites. So these examples that I mentioned just now, the studies are conducted in one country or one region. So it is not as challenging to standardize the enrollment criteria, the assay protocols, and the data sharing agreements, etc., when compared to studies that are conducted across multiple countries or regions. So therefore, when we expand these efforts into multi-centers in different countries and regions, we really need to establish an easily accessible database that can facilitate better information sharing. And this can be very challenging because the policies on recruiting participants, obtaining consent, collecting samples and data, and storing data can vary a lot across countries and regions. And also the data content and the format may also vary a lot within cohorts because of the differences in language or culture or even living characteristics. So it makes the data standardization very difficult. So one suggestion I have in order to facilitate data collection and standardization is that we might consider using regional data platforms that can support the different cohorts that share similar characteristics. Another suggestion is that we can use some advanced architecture, such as federated learning, which uses data without actually sharing the data. So the federated learning can use it uses the concepts of sharing model parameters without using the raw data for collaborative research. So researchers from one center can build a model using their own data, and then share the model with other research groups. And so using this kind of technology, the data collected from multi-centers can be effectively used for developing tools for disease diagnosis or early prediction without actually transferring the raw data across centers. And Hong Kong can be a regional center to support AD research in Asia. We actually have been serving as a regional hub for international collaboration research on Parkinson's disease. And we have been coordinating the data collection, analysis, and we hope that we can also support the AD projects in Asia. Thank you.
Thank you, Nancy. Is Tarun back on?
I am using my phone, so apologies. So I got most of Nancy's presentation, so thank you very much on these innovations that you talked about. So I think I'm going to summarize the key lessons from all the 4 panelists that we heard. So we heard about the importance of sharing and learning, and that was emphasized by Martin as well as Nancy, and innovations and the way that can be done, for example, for data. So great examples provided by Nancy. Soren talked about how we need to focus on some of these scalable technologies, and then Jennifer provided 2 important points that can help us in scaling up. One is including dementia awareness as part of our strategies, but also piggybacking on what's already happening. So I know we are kind of over the time, George. I don't know whether you want to have some cross-questioning now or you want to move on.
I think we ought to move on, although Stephen asked a simple question that that Martin can answer, and that is, when do you think you might go public with your work?
He's already typed, Martin. Yes.
Soon, George. Soon. I put an answer in the chat as well. So
okay, thank you.
Happy to engage with people. I'll put my email address in there. People can get me. That's fine.
Thank you, Tarun, and your panelists. I think Nancy sort of at the end sort of took us from a place where what is the problem to beginning to think about the sharing that's going to be needed just through standardized processes, regional or global, to take data that we learn from any particular country, health system, or cohort, and integrate it around the world. So that's there. Nancy is deeply involved in the operations of DAC and has been a real source of insight, strength, and leadership in this. So we thank all 4 panelists, but Nancy, thank you for your work operationally. This is your discussion was a real segue, a great segue to our next panel, moderated by our good friend Phyllis Farrell, on how DAC's community of practices will actually begin to work. Actually, how are we going to start working with the people on the ground, so to speak, in health systems in different countries to begin to learn from each other, what we're doing, how we're going to measure, how we're going to share those learnings. So this is going to be an interesting panel of a number of our, what we're calling flagship programs this first year, since we only launched in January. And I look forward to it. Because at the end of the day, if we can't put into practice what we're talking about, all of this is simply hypothetical. So to you, Phyllis, thanks for taking on this panel.
Thanks, George. And yeah, we only recently launched, but we are moving with lightning speed. And so I'm really excited about this panel because we're going to kind of double click now on one of those nodes that we saw in the patient pathway, and that's specifically the early detection, and really looking at how do we take some of these global concepts and make sure that they get to a patient and they really get operationalized. And you mentioned this already, as well as Professor Knapp, the ability to share between countries it's really important that the solutions won't just fit for high resource countries, but they'll fit for low and middle income countries as well. And in fact, the learning can go both directions. And in a lot of cases, we're going to learn a lot in high resource countries from those low and middle income countries, because they're scrappy and they're going to figure out how to get some of these things done. And we may find some simpler ways to attack the problem. So this first problem that we're attacking is the early detection. And DAC intends to achieve our goals by two interrelated approaches. One is to develop a funding mechanism that's going to encourage and support multiple diverse projects. But we're going to look at them with common lenses, nomenclature, measurement, so that we can share across countries. And then doing what we're doing today, which is bringing together representatives of healthcare systems from multiple countries and basically tackling the same problems, but maybe tackling them through different perspectives, so we get more well-rounded solutions and maybe different options. And you're going to see that today with our panelists. So our first flagship project is targeting timely detection. You're going to see an overview of that project on the screen. And so while science has made these recent breakthroughs in disease modifications, the disease modifying treatments will have to be used in the earliest stages of the disease. But today, dementia is only diagnosed, if it's diagnosed at all, in a very advanced stage. There's substantial risk that patients may not be identified early enough to benefit from these new innovations. So this pilot project is looking at raising awareness for the importance of cognitive evaluation and working with frontline healthcare providers to increase the proportion of their elderly population that has an annual assessment of their cognitive function. We want that test to be done just like a cholesterol test is. Let's make sure we know what our brain health is. Let's know every year, and let's make sure that that's documented in the electronic medical record so we can measure change over time. So in short, we're going to use these various touch points with frontline healthcare providers to offer the older population a brief digital cognitive assessment. And this could occur during their annual visit, or it could be because they come in asking about memory. If they're suspected of cognitive decline, as Soren mentioned, it's incredibly important that we understand what the source of that cognitive decline is. There are a lot of things that can mimic Alzheimer's disease in terms of cognitive decline, and we want to make sure that we have an accurate diagnosis using the biomarkers that are in a recent addition to our clinical opportunities. And so we will then take a look at the pathology and see if we can get something that would help the doctor with that diagnosis. All the patients will receive kind of counseling and training on those risk factor modifications that Professor Knapp mentioned around the finger study. They might hear about cognitive training, and patients whose disease state allowed it, they may be referred for a clinical trial or registry, potentially offered a wait list for the potential future availability of a treatment, but most importantly, they'll get the care and services that they need. So this evaluation will combine both quantitative and qualitative analyses in a mixed methods approach. The goal, of course, is to increase the proportion of older patients with a documented cognitive status. But what we really want to do is dig in and understand what are the facilitators and what are the barriers for frontline practitioners, because they could be doing this today and they're not. And it's not because they're not good doctors, it's because there's operational barriers that they're facing. So how do we uncover those in a systematic way and make sure that we're removing those barriers so that patients can get the best care? So we can bring that slide down, and I want to introduce our esteemed panel. I'm actually going to ask them to introduce themselves. So we're really excited that we have 6 countries that have committed to be part of this flagship initiative. We've picked those leading innovators that are willing to lean forward with us. They know that there's going to be some bumps and bruises as we try to do something new, but they're willing to both do this to influence their own healthcare system, but also to play a role together on this global stage. So let me, what I'll do probably is call out the names and we'll go in order. And if each of you could give your name and your role, your affiliation, if there is one, and why do you think it's important to participate in this initiative? Craig, can I start with you, please?
You can. Good afternoon, good morning, good evening, everyone. My name's Craig Ritchie. I'm Professor of Psychiatry of Aging at the University of Edinburgh and Director of a new initiative here in Scotland called Brain Health Scotland. Important to participate in this. I've probably got 1,000 reasons for that, Phyllis, but I think I'll limit it to the top 3 just for the sake of time. I mean, number one, I think, is this initiative will unlock a topic that, as you said, has been locked into academic circles for way too long. I think this is an incredible opportunity to get research into practice. And I think that's one thing that's really motivating. And I think the second point that really excites me about this is I think for a long time within those academic circles, we've known that Alzheimer's disease is a brain disease with cognitive symptoms. It's not a late life cognitive disorder. It's a brain disease. And the way we're approaching this, I think, recognizes that and allows us to detect the disease as early as possible to give us the best chance of prevention, and doing so at a healthcare system level rather than necessarily just within cohort studies or clinical trials. And the third reason is we really wanted to participate because we wanted to be part of something with friends and colleagues around the world, because we wanted to learn from other people, other systems, other settings, and hopefully we can share those learnings. So those are my top 3 reasons for wanting to participate.
Thanks, Craig. Atello, let's move to Brazil. And I think you're still on mute, so I'm going to ask you to unclick that at the bottom. Great, thank you.
Good morning, good evening, everyone. I'm Otello, I'm a physician, I'm a psychiatrist and training psychoanalyst. I'm very proud to make part of this group. I have a extensive experience in managing primary care and elderly care projects. I'm now independent consultant in University of Southern California and the principal investigator of the Flagship product in Brazil. I'm very proud about that. This initiative opens up a new possibility for the early detection of Alzheimer's disease here, as well as integrating elements of a diagnostic chain that will allow the generation of a research model on timely care for AD patients. My team and I have two people with me, one researcher nurse and a psychologist. Both are teachers, college teachers at university in Rio de Janeiro University. And my team and I are very excited and committed to this project. So very proud to make part of this. It's a very nice opportunity for Brazil, for Rio de Janeiro, and we can change this challenge. Thank you.
Thanks, Otello. We love that Brazil is really driving us ahead. You guys are moving super fast. That's great. Steve, why don't you tell us about the US?
Yeah, good morning, afternoon, and evening to everyone here. So humbled to be amongst such talent and energetic people. Phyllis, thanks for your comment about problems can be solved with resources and commitments. Absolutely correct. What resources and what commitments? That's really what I'm learning about today, and that's pretty cool. So you asked me to share some of our views of barriers to earlier detection of cognitive symptoms and what we hope to get out of this. Let me start by saying a special thanks to Professor Bloom for highlighting the economics of the problem. We believe the key is to unlock the opportunity, at least in the US healthcare system, is aligning the patient population and political goals with the economic incentives. The US healthcare system is an economics-driven system, and physicians are rewarded on a daily basis for excellence and quality. Examples include cholesterol, blood pressure, diabetes management as effective means of controlling cardiovascular disease. We've done a pretty good job of that. We create digital dashboards for our primary care physicians that track population testing, blood pressure control. We've done this before, and we'll do this again in Alzheimer's screening and diagnosis. But first, we need to establish and prove out a system of screening and early diagnosis, and that's what we're excited about. The system has to be easy, accessible for all communities, and lead to outcomes that serve our patients. And importantly, it has to be done without creating a negative economic impact that prevents its implementation. One last comment I'd like to make is that historically, we've taken a physician-centric view. That's been our dominant model for creating change in healthcare systems, but this is changing rapidly. We believe in a patient consumer-centric model that the healthcare system will need to create digital solutions that make it easy for primary care physicians. Our consumers are increasingly digitally savvy, and we think that this is going to be key, at least in the US. And our hypothesis is that a system-level view needs to be applied to supplement, support, and enhance physician-initiated efforts. And we need to learn and build on what we've accomplished in cardiovascular disease screening systems. And then lastly, we need to do the hard work, Phyllis, of getting payers to incentivize this work. If we don't align the economic incentives with the desires and needs of our population, we're not going to be able to implement systems at scale. So we're really excited to take part not only in the research here, but in the governmental, political, and all of the other energy that needs to be applied from a grassroots level to support what we're doing. Thank you all for teaching me today. It's great to be with you.
Thanks, Steve. Yeah, you hit on some of the highlights on why it's so important that this healthcare system preparedness is very holistic, that we look at all the key stakeholders, and we'll circle back there as well. So while we're doing introductions, Kowa-sensei, Kobe City has really been leading the charge. I mean, obviously Japan, a super aging society. Would you just take a moment to introduce yourself and let us know why you think it's important to be part of this initiative?
Sure. So hello everyone. I'm Dr. Hisato Mokoa, a professor of Kobe University Graduate School of Health Sciences. I'm a neurologist-based researcher on Alzheimer's disease and related disorders. I'm now a co-PI of Japanese finger study, randomized control trial of multimodal intervention for preventing dementia. And also I'm a co-PI of the Japanese trackpad research. And I believe dementia is a long course disease, and we have a lot of things to do on each stage of the disease. And recently, even the clinical trial of disease modifying therapy is targeting the very early stage of the disease. So I really think that early diagnosis and early detection of cognitive decline for higher risk of the people is very important to prevent worsening the symptoms. I think this DAC project is trying to establish the system of early and correct diagnosis of AD. And I'm really honored and pleased to join that project. Thank you very much.
Thank you, Kowa-sensei. And you hit on, I think, an important point that I didn't mention earlier, which is why start with early detection when we think about the patient pathway. And the reason we did that was we saw that there was spillover benefit going both directions, both encouraging earlier detection and brain health awareness, as well as the downstream benefits. So thanks for highlighting that point. Okay, so Luis, you're joining us from Mexico. Would you care to introduce yourself and why you're interested and excited to be involved?
Jess, it's a pleasure to be here. Thank you so much, Phyllis. Thank you to all those who are promoting this initiative. We are very proud to be able to be here together. I see that Mariana Lopez Ortega and Raul Medina, researchers from our institute in Mexico, are here with us today as well. And it's interesting because, in fact, we've been in the field of dementia for almost 30 years now. And finally, we are on the verge of an opportunity to go into implementation of what we have been learning and discussing through the years. We have been involved in the STRIDE project through Mariana Lopez Ortega, and we see this opportunity as a continuity of such a project moving now into clinical practice. Indeed, we are aware of the need of to involve the whole clinical team and not only the physicians. And there is a very interesting opportunity from that point of view, moving together. We are working as well with WHO and the International Association of Geriatrics and Gerontology in the development of the ICOP, the Integrated Care of Older People Initiative. And there is a convergence of interests here, and we feel that we can move forward with both initiatives in the same direction, enabling primary care physicians and removing the barriers that are there for them to be able to participate in the early detection of Alzheimer's disease and related disorders afflicted patients. So thanks so much for the opportunity. We have already begun learning from our partners, and I believe that it will be a wonderful experience from now on. Thank you.
Thanks, Luis. Yeah, this is our community of practice, and you all will get to hear a little bit from Tim McLeod, who's running this community of practice we have in front of us. But boy, it's so much fun to see you all on the screen. So we're going to do one more introduction before I dive into some deeper questions. And Ishtar, you've joined us from Jamaica. So would you like to introduce yourself? And I know you've already been referenced a couple of times as being part of the STRIDE project as well, but let us know why you're interested and excited to be part of DAC.
Sure. So I'm a senior lecturer in epidemiology at the Caribbean Institute for Health Research in Jamaica. And I'm also the lead for STRIDE Jamaica. And for us, it's really important to participate in this initiative because we see it as a real opportunity to contribute to transforming the rules of engagement with low and middle income countries for these ADRD innovations, so that we're not just implementing the ideas as presented from high income countries, but we are speaking to our local needs and we're having our expertise valued in the design and prioritization processes. And that way we can have solutions and innovations that are really fit for purpose for our context, a way that really realizes that innovation-driven solutions and research have to really be innovative to the context in which the majority of the burden lays now and is projected to lay in 50 years, in 30 years. So these innovations, as we've seen from the STRIDE project, they have to be multidimensional. They have to be social innovations that address stigma, that address care pathway needs, and they also have to be those that we typically assume to be innovations when we use that language, such as technology and pharmacological innovations. Another very practical reason that we're excited to participate in this initiative is that it helps us to continue in parts of work that were started with STRIDE, but which we do not have funding for. So to work in a really complementary way, as we've discovered gaps, as we've discovered needs, and to really think through how these resources from this initiative can help us to create a comprehensive dementia care, brain health care system.
Thanks, Ishtar. You hit on two really, really important points there. One is that the work group that assembled the healthcare system preparedness plan wanted to make sure that we were not competing with related initiatives, and that in fact we looked for all those synergies. There's just not enough resources for us to compete with each other within the sphere of Alzheimer's disease. So you'll see and hear a lot of complementary synergistic views as we work through some of these related initiatives. STRIDE's obviously one that's been mentioned multiple times already, but there's many others. Additionally, this concept around making sure that while we're together as a community of practice and we're looking for common objectives, common underlying principles, common guiding principles, at the end of the day, all the solutions have to be able to be implemented locally. And so I think we've looked back at some other analogies in other disease states where global solutions were dictated because the funding came from these higher level institutions and organizations. But when the solution hit the local environment, they weren't operationally feasible. So we're working really hard to make sure that we can tease those things out. And that'll be part of what this community of practice does together. So let's dive in just a little bit. We have a little bit of time, and I'd like for you each to get to speak a little bit about the specifics. I know we've hit a couple of them already, but Craig, you know, Scotland has been a leader in Alzheimer's disease and detection with a critical collaboration with the NHS. And that close partnership has actually driven innovation in infrastructure for you all. Can you talk a little bit about that and really what advice, you know, this is our first learning lab. So our goal here is to give a little bit of advice of what you would have for others in establishing that kind of tight collaboration with the NHS.
Thanks, Phyllis. I'm not sure if it's advice or maybe just sharing experience and see if people think it's advice or not. But I think we've been really fortunate. We've been, leading a lot of research projects like Prevent Dementia and the European Prevention of Alzheimer's Dementia project going back almost a decade now. And I think we got a point in those studies where not only were we looking at the data, but we were having literally thousands of conversations with the participants where they were saying, these are studies in midlife and people at preclinical stages of dementia. And they were saying, look, we need to do something about this, not just about research, but actually do something in practice. So I took that kind of conversation and channeled it to a meeting I had with the Scottish First Minister about 3 years ago. So in some ways, what we've been doing in Brain Health Scotland has actually had its foundation in Scottish government, rather than coming from an ivory tower to try and implement. It's actually starting in Scottish government. And we've talked a lot over the course of the last couple of hours about sort of a systems level approach. And we're very fortunate in Scotland, as we are indeed across the UK, to have a national health service. And it means that a lot of the component parts of that system are within one organisational structure. So if you can get leadership, in our case from the First Minister and from the Health Minister, to say, yes, we should do this, and it's in our programme for government in Scotland about dementia prevention and Brain Health Scotland, then that unlocks a lot of support from various parties within government. You need the data scientists, the people working in Active Scotland about sports and exercise, nutrition. They're all onboarded to this sort of system level approach. So I think we've been quite fortunate in a way. We've had the research evidence. We've been able to get a ticket to speak to the First Minister, but we've also got a system in place which I think is ideal for this kind of initiative. And dare I say it also, we are a very small country for 5.2 million people. So I think it's possible and it's feasible to change the whole system at that national level, as would be more challenging, I think, in larger healthcare systems. So I don't know if that's advice, but that's just my experience.
Craig, it's very helpful. And I know that your colleagues that are here on the screen are going to pull on you a little bit for those experiences as well, because you have been quite effective in the development of Brain Health Scotland. So Otello, let's build on that a little bit and move to Brazil. Brazil's not likely to be a geography that would be the first one to have access to some of these novel innovations, diagnostics, therapeutics. And yet you've been one of our quickest moving flagship sites. You very quickly had local municipalities and health ministers and your community leaders involved. A little bit of like what Craig was just saying. How did you find that foundation? How did you find those forward-leaning participants in the government to work with you? And once again, I'm going to ask you to click on your mute button. There you go.
Well, may I disagree a little? Brazil has a public health system that provides free care to all its residents with a solid structure of primary care. The family health strategy consists of primary care teams and strong municipal management, which brings the elderly very close to preventive programs. Neurology and geriatric societies also play an important role in disseminating prevention and care for Alzheimer's disease. And FEBRAS, a Brazilian Alzheimer's Association, leads action related to the rights and care of patients with dementia in a strong form. On the other hand, Volta Redonda is a municipality with, it's a very interesting municipality, has a lot of primary care units, have a steel mill factory, enormous to bring steel to give steel for exportation for the world. It's a very important municipality in Rio de Janeiro. and have one unit for exclusive care for the elderly and a care center for people with Alzheimer's disease. Has a care for Alzheimer's disease in Volta Redonda. It's incredible. In addition, there is an important involvement of the municipal health department and its managers. I really try to have a positive leadership role in this project, encouraging the team. That's worked with me a lot and discussing the project with the local managers. It's still a strong point in this program of free, it's still a strong point in Brazil. There is a free distribution of high-cost medicine to the population. And the policy of incorporation of new technology by the Minister of Health, which in a way will facilitate the population access and approval for new therapies for Alzheimer's disease. It's a very important, because Anvisa goes on in the FDA, and it's a very important point to approve of modify this therapy in Brazil. Volta Redonda also has a School of Medicine and a local ethics committee, IRB, local IRB in Volta Redonda, because they have a School of Medicine. So that will be facilitate elements of the project, the approval of the project. It's a very important. Okay, the possibility of working together with Soren and the USC and the Solid DAC Providence are certainly strong support and the stimulus for the planning and development of the project. We are very committed to that.
Well, Otello, I'm still going to give you credit for moving very quickly, but I think your point about primary care just reinforces why we need to make sure that the operational solutions are customized locally, because we will have those countries that are really leaning on primary care. We will have others that really move into specialties. So I'm going to pivot to Steve about the US. And Steve, you've already mentioned a little bit about barriers and facilitators. Clearly, the US is not the type of national healthcare system that Craig mentioned. We're very fragmented. We do have integrated disease verticals, but Advent Health was an important selection for us as we looked at where we wanted to partner in the US. And one of the reasons is this point that you mentioned about system and system thinking, and this has come up a little bit. Can you tell us a little bit why Advent, you think, specifically fits so well in system thinking and kind of holistic care, and how you all approach patient care? I think it'll help our listeners understand why Advent Health was such an important choice for the collaborative.
So we have a long tradition of whole person care within the healthcare company, that we understand that we are more than just our cells and tissue and such, and that our environments and indeed our own health is really dependent upon the whole person. And so we see Alzheimer's as an opportunity for us to bring that approach, not only through systemization and making sure that each of our patients has access to these kinds of screening processes and the ultimate diagnosis and therapeutics, but that we engage our entire community wherever we serve in our 9 states with 50 different hospitals, that we provide the same level of care across the system in our big hospitals as we do in our smallest clinic. So I think that philosophy is really one that's important.
Thanks, Steve. I appreciate it. And we're going to look forward to you playing a real leadership role for us across the US. I know your team is on and thinking about how to do that. So let's move to Japan and Koa Sensei. You know, we mentioned that Japan's a super aging society. Japan has already played a leadership role. Kurakawa-san is actually going to take on a co-chair role as part of the World Dementia Council, which is fantastic. Kobe City, though, has been a leader within Japan. And you all have a very unique model where you've already been going direct to patients to encourage cognitive assessments. And you have a great partnership with your insurance system. What are your fundamental goals? What can you share with us briefly about the Kobe City model?
Sure. So here in Kobe, we have established a 2-step diagnostic support system. The first step is an initial cognitive function checkup performed by a family physician, not a specialist of dementia. to establish actually without not the old people has the presence or absence of suspected dementia using a series of tests and questionnaires. It's fixed because they are not specialists. But then if someone cannot get through the first step, then they must go to the second step. The second step is actually the detailed examination by a specialist to confirm a differential dementia diagnosis, including MRI imaging and conventional, not tau or no other special test, but the conventional blood test. And the problem with the convened model is actually the accuracy of the disease subtype. It is very hard to make underlying pathological diagnosis. Amyloid PET is still available for just research only, and lumbar puncture process is very time consuming and not realistic for the Japanese busy clinics. So we really need, actually the system is already established, but still we need more, how should I say, more technology to improve the diagnosis. So I'm looking forward to using blood samples to diagnose Alzheimer's disease, which will improve the accuracy of the disease for taking part in that project. Okay.
Thank you very much. And I know that we'll probably get into more detail on the Kobe City model as we have a little more time with our community of practice, because it is quite extensive and impressive. Luis, I'm shifting gears just a little bit to talk about kind of related initiatives and synergies, since we do have our Learning Lab, the World Health Organization's ICOPE. That's an initiative that is that's being spearheaded by the World Health Organization, and you're moving very, very quickly on ICOPE, and it was one of the reasons that Inger was such a good partner for us. Can you give us just a quick highlight? I know we're a little short on time, but a highlight on ICOPE and how you see these being synergistic.
Yes, absolutely. The provision of integrated care is key for older people, and the WHO guidelines on integrated care for this purpose propose evidence-based recommendations for healthcare professionals. We began working on this issue in 2015 together with Martin Prince, who has been the lead person for the 1066 initiative. So that you can see that the interest from the dementia field and the geriatric medicine has been there from the outset. And we have at our institute, the National Institute of Geriatric Medicine, a WHO collaborative center on integrated care of older people. And we work very closely together with the Toulouse Center, which has the same interest, led by Professor Bruno Velas. And an initiative has been developed in order to involve primary care physicians and enable them to deal with the more frequent issues of healthcare of older people. Algorithms for care and clinical pathways have been developed, and we are already on track for the validation of this initiative. Together with this, I would like to mention also the MHGAP initiative, because currently here in Mexico, we have recovered this initiative, and we are moving as well from the psychiatric direct center in the Ministry of Health has been moving forward into this initiative, enabling primary care physicians as well to use the app. The ICOPE app, which is the phone and a cell phone based application, has been developed, and as there is one for MHGAP as well. And primary care physicians are being taught how to use these protocols, and we are moving together from our role we are in a key position. We are advisors to the Minister of Health, but at the same time, we are research and a teaching institution, and we are in touch with all the segments of the healthcare system in Mexico, which is much more complex than Brazil. It's not straightforward and easy to move into, but we have been fortunate enough to be working for more than 20 years with the Alzheimer Federation in Mexico. And this non-governmental organization has been key to showcase the issue of dementia and to move forward specifically in Mexico City. And they have created a very fertile ground where we can collaborate and develop this specific intervention together with Mexico City's Ministry of Health and Mexico City's Ministry of Social Services, which is also very interesting, working together with both.
No, I think you bring up wonderful points there of some of the non-governmental partners, and it's probably important you and Otello both mentioned, and Craig too, I know has a very strong relationship with your Alzheimer's advocacy and social service organization. And Alzheimer's Disease International is a strategic partner for us on this initiative. We will rely heavily on their members. So Ishtar, I'm going to give you the last question here. As we are running out of time, I know we could keep going, and we will. But you are have already mentioned lack of resources in low and middle income countries, both within the healthcare system and in the outside of the healthcare system for some of this post-diagnostic support. Can you share just a little bit of your perspective on these challenges and why you think this project will be helpful, not just for Jamaica, but for also low and middle income countries? I know that's very important for the World Health Organization and the World Economic Forum as well.
Yes, the challenges are multiple, and in answer to those challenges, I just want to also emphasize that there are innovations, again, not necessarily technological or pharmacological, but we are making moves even in resource constrained contexts, like what our earlier panelist Jennifer was mentioning. So in terms of barriers within the healthcare system, first of all, we do not have electronic health records implemented. Those systems are not implemented in Jamaica. And even when there is a process for implementing them, it's going to be very different from one entity to another. And so some of the challenges that were talked about earlier by Nancy in terms of harmonization of those different data systems are going to be crucial for us to anticipate. Secondly, we do not have any memory or brain health centers. And so this means that there are real limitations in terms of where you can refer persons to after. We don't have tests and medications available in the public healthcare system. And in the private healthcare system, these diagnostic tests are extremely expensive and so perpetuate great inequity even within our countries. There is a lack of insurance coverage for long-term care or anything that is dementia related. And across all countries, including Jamaica in the Caribbean, there is COVID-related burden on the healthcare sector. And so we've already been existing with stretched resources, and those resources are stretched even further now. Outside of the healthcare system, there's a reliance on informal care for those needing long-term care and for those with any type of brain health challenge. The Alzheimer's associations within the Caribbean region and definitely within Jamaica are not very functional at all. They have limited activities occurring, and resources tend to be very concentrated in urban areas of the country. Additional barriers include, as already referenced, a high prevalence of stigma related to anything related to brain health, anything related to dementia, anything related to Alzheimer's disease. And there's often a conflation of mental illness with dementia, mental illness with anything related to brain health. And then very importantly, outside of the healthcare sector, the key barrier is that we need buy-in. We need buy-in from our national governments, and we need buy-in from governments and cross-country regional types of associations and governing entities. So I think this project in particular could be very helpful for other low and middle income countries, because what it will help us to understand is what exactly does timely diagnosis mean? And that will differ quite likely for different stakeholder groups. And it will help us to understand as well the need for and the buy-in around timely diagnosis, including the willingness to allocate relevant resources.
You know, Ishtar, I think you've set up our Luis, you're not on mute. Ishtar, it's okay. Welcome to Zoom friendliness. Ishtar, you just basically segued right to our next speaker. And so I first of all want to thank all of you and tell you how grateful I am for your energy, your passion, your efforts, all the work that you're doing, both together when we're together and getting your own sites up and running. But you are our community of practice. And as Ishtar mentioned, there's these common themes that we want to use design science and implementation science to pull out so that we can scale these learnings outside of just these 6 healthcare systems around the globe. So I'm going to turn it over to Tim McLeod from Bridgeable, who has been leading this community of practice initiative for us. Just trying to give the group here on the call today, Tim, a little bit of a glimpse of what we're going to do with this information. So thanks for being here.
Yeah, for
and you
sure.
bring in one more country, so bringing Canada in. So thank you.
Yeah, thanks so much, Phyllis. So I want to talk about, following up on all of the health settings that we just heard from. How do we scale local learnings into global best practices? And so to make this really tangible, I actually want to start from the perspective of where does health innovation fall down when it comes to adoption? And I want to use a really simple case study to highlight this. And then I'm going to talk about what we're doing differently in the Flagship project to make sure we power adoption globally. So on the next slide, I want to start with the health innovation of the lemon. So in the 1700s in Western Europe, the economy was very mercantile and maritime trade was very important. And scurvy was a leading cause of mortality and illness among sailors. So it was a significant economic and social problem. And so this guy here, James Lind, ran one of the first recorded early trials or controlled experiments where he took 20 sailors on a naval vessel and randomized them into either a control group or receiving lemon or malt vinegar, essentially to figure out what might work to treat scurvy. And so he found lemons are really effective. And so you would think, given the importance of the problem, both in economic and social terms, the Navy would have just adopted lemons immediately and put them on ships. And predictably, that's not what happened. So it did become standard practice, but not for 50 years. And so James Lind didn't live to see this happen. And so if we abstract forward to today, I think that we can see this persistent gap in innovation or discovery and adoption that existed in Lind's time and still exists today. And so I think there's 2 facts we should take. So one is establishing the effectiveness of an intervention does not equal its adoption into routine practice. And the second is empirical research shows today when innovation is adopted, it typically takes 20 years between sort of discovery and widespread adoption. And so I think that the stakes of the problem here are really like our methodology and tools for outcome research on efficacy and effectiveness are amazing at understanding what works for who when. They don't and aren't designed to think about what factors affect routine adoption. And so implementation science in the last 20 years is a field of study that's really emerged to shorten that gap between discovery and adoption. And so to boil a complex field down very simply, what we're talking about here is identifying barriers and facilitators across multiple levels of context. So from health system policy all the way down to individuals in treatment, and using those barriers and facilitators to develop strategies that overcome barriers and enhance facilitators to really close that gap. And so to make that really practical, if you think about the lemon example, although Lind was able to show that the lemon was effective, he published his findings 8 years later in a 450-page treatise. So at a policy and practice level, there was strong barriers to uptake, right? Like people didn't understand what it was, they didn't understand the recommendations. And then even a remarkably simple intervention like a lemon, you would think would be easy to translate into clinical practice. But what ended up happening was early adopters cut the lemons up and juiced them and boiled the juice down to save space on the ships. And of course, the treatment didn't work because they didn't implement it as intended. So I think that this gives you a sense of, outside of the realm of efficacy, there are a number of like social factors that are really important in understanding what gets adopted into routine practice. And so jumping forward to Alzheimer's and the DAC group today, we've developed a number of overlapping and mutually reinforcing strategies pulled from implementation science best practices to really close that gap between innovation and widespread adoption. So as Phyllis mentioned, we've put together a community of practice to share and document ongoing barriers and facilitators to planning and implementation. And we've made sure that we have representation from very different contexts, from different low, medium, and high income contexts, so that our findings are representative. In our study protocol, we've included qualitative structured interviews to document barriers and facilitators in a systematic way. And we're bringing those two pieces together into 2 community of practice labs, where we will consolidate, document, and synthesize the high-level barriers and facilitators to implementation, as well as strategies in different implementation contexts, to make sure we've got solid strategies to get over barriers and facilitators. And all of this will coalesce into a digital toolkit. So when we think back to Lind and his like 450-page treatise, we want to make sure that very soon after study summation, we've got a highly usable toolkit that's explicitly built for policy makers and providers to very quickly translate lessons learned into practice and adoption. So thanks so much for your attention this morning. Really looking forward to the road ahead and to updating people on progress as we go forward.
Thank you all, Phyllis, for such an extraordinary set of panelists and the work that you've done in enlisting them, and then the energy that they bring forth and ideas that they bring forth on what they want to try to accomplish and what in their settings makes more sense. So I think now is the time for questions. If anyone has any questions, please just either raise your hand, put it in chat. Raise hand function, as you know, is down under reactions, at least on my screen, in which you have a little raise hand function. So you can raise your hand and we will call on you for a question. Otherwise, you can put it directly into chat. So this is your time if you need it, want it. Let me ask, I'm going to ask a question of Phyllis. And Phyllis, this is the inaugural sort of kickoff meeting for this Davos Learning Lab. What is your sense of pace on how frequently you'd like to sort of have this particular format repeated? So, I mean, is this a once a year, twice a year? What is your thinking about that?
Well, it's a question I'd probably like to ask our community of practice, these experts. They're going to meet very frequently because they're going to have a lot of learnings as they set up this project. And then, of course, as the data comes in. One of the things we wanted to do a little bit differently than some other grant projects is these are short and bite-sized projects. You know, our goal is to run them for 6 months, collect the data, do the analysis, and be able to report out very quickly. So I don't think this is necessarily going to be on any one project, these long multi-year conversations. I think it could allow a learning lab where we report out to governments and the key stakeholders around policy every 6 months or so. But I'd love to test that assumption with the community of practice. I haven't done that yet.
Okay. Well, let me go ahead then and summarize what I think I've heard this morning as 4 action items that we need to take forward. I took it from Jennifer's comments. We need to overcome stigma, broaden the understanding within the patient community and the healthcare system that a checkup from the neck up should be as routine as a checkup from the neck down, and that an early, accurate, and compassionate diagnosis of brain impairment is not to be feared, but it is something which is actionable, whether through a non-therapeutic activity or therapeutic activity. Second, that we need to introduce new tools and protocols Soren emphasized, as did Nancy and others, the need for blood-based tools, develop and disseminate easy to use, low-cost tools and protocols to detect, diagnose, and care for people with brain impairments, including Alzheimer's, including both risk reduction and emerging therapeutic options. Adopt incentives for change. Identify incentives for physicians and for health systems more generally to change their professional, use their professional skills to introduce change into clinical practice in order to achieve these goals. And finally, creating a learning community, which we're still inaugurating today, to create a broad base of comparative barriers facilitators to adopt practices across different regions of the world, but practices that may vary, as Ishtar emphasized, that reflect local community needs and patient needs in different settings. So this healthcare system preparedness effort that we have discussed today are linked to two other programs of the Davos Alzheimer's Collaborative. Building a global research system by linking and scaling cohorts, discovery cohorts from high, low, and middle and medium resource countries, and building a global clinical trial support platform. We can't do this alone. I hope that this is the first of many conversations where we can come together and share our insights and opportunities for collaboration and progress. I encourage each of you to reach out to us so we may include your ideas and insights on the ways in which we can advance our efforts. Looking ahead, there's several milestones of this particular work stream. Our flagship program is kicked off, and we're going to see our first results hopefully by the end of this year. Our flagship site leads, as Phyllis mentioned, will continue to meet regularly throughout the duration of this project to share their successes and milestones and their failures so that we can ideate increasingly in an interactive and continuing dialogue on how to address barriers that are facing the field and operationalizing efforts to bring greater attention to brain impairments. This program will also issue its first call for proposals this fall. So you've heard from 6 of the flagship programs, but we're actually going to ask health systems around the world to sort of raise their hands in terms of including other health systems, their local efforts in this particular initiative. We'll include each of you on this announcement. I hope you'll spread the word across your networks. And I look forward to reconvening end of year, early next year for a readout from the first 6 months of this DAC Learning Laboratory. We'll be in touch this fall with a save the date. Look forward to working with each of you, all of us at the Davos Alzheimer's Collaborative and this health system preparedness team. Look forward to working with each of you through the Davos Alzheimer's Collaborative to advance our efforts and achieve our mission of eradicating Alzheimer's. Deeply appreciate your being here today and spending some time with us, sharing your learning, sharing your engagement, and sharing our mission together. Thank you very much.